So 5, 4, 3, 2, 1. We are live to the audience. Over to you, ma'am. You can start the session.
Good evening, everyone. Thank you, all the listeners and the young, vibrant people who have joined in great numbers. Thank you for joining and being here today. At the outset, I would like to thank ICS, Dr. Samaria, Dr. Rajadhar, Dr. Amita Neni, and the Lupin platform, which they have given us to be here today and to make this a rocking session. So it is indeed a very great day. So let's see for the next, say, 1.5 to 2 hours, we are going to take you through progressive pulmonary fibrosis. Over the years, we have understood that ILD has evolved from simply labeling them as IPF or not as IPF to recognizing that we have a significant proportion of non-IPF patients who are fibrotic ILDs who progress. And then we came up with the name of PPF, progressive pulmonary fibrosis. So this is what we are going to be discussing today, which is not just an academic label, but a practical clinical challenge. So today our journey will be through day-to-day dilemmas. It's not about theoretical definitions. It's going to be a day-to-day dilemma grounded in guidelines and evidence with a focus on what truly matters for practice. I am delighted to have with us an eminent panel of experts who are stalwarts in their own fields and in their own interest, who are very, very good, who have experience in ILD. So they will help us to decode our nuances with their crisp, clear, and evidence-based insights. So I am looking forward to a great talk and a panel discussion later. So with that, we will introduce our speaker for today, Dr. Rahul. Can I have the slide for introduction, ma'am?
Yes, ma'am, shared.
Yeah. Okay. So this is Dr. Rajesh, who's going to take us through PPF in a crisp, clear manner and a short presentation. I think over the next 20 minutes, he's going to show his charm. So he is hailing from Kottayam and he's currently a senior consultant and HOD of Pulmonary Department, Kochi. He is the recipient of Dr. Santosham Memorial Gold Medal at the national level in DNB Medicine in 2006. He's a recipient of Young Pulmonologist Award of Academy of Pulmonology and Critical Care Medicine in 2013. He's an inspiring chest physician and also been awarded the same in 2023. He was also an organizing secretary to the NAPCON 2019. We all know about it. And he has given around 120 guest lectures at international, national, and zonal level, 90 publications in reputed journal. Thank you so much for being here today, Dr. Rajesh. The floor is yours. Please go ahead.
Thanks a lot for those kind words, madam. And at the outset, again, as you just correctly said, I would like to place upon record our sincere gratitude to the ICS team, Dr. Samaria, Dr. Rajadhar, and the ever vibrant, the live wire of this, the scientific endeavors of Indian Chess Society in the form of Amita madam. And I would again like to place upon record my sincere gratitude for allowing us to be a part of this very important session. I'll just share my slides. I hope my slides are visible.
Yes, sir, it's visible. Yeah.
Not opening for me. It's visible, but visible for others. It's not opening for me. Welcome. I'll just stop here and once again share. I hope it is visible.
Yes, sir, it's visible.
Okay. So the next 20 minutes or so, I will try to share with you the concept of progressive pulmonary fibrosis. And that's Madam Thilagawathy has very correctly said. It took us a couple of decades to understand that even the non-IPF ILDs of varying etiologies have something in common in a selected subgroup of patients or selected small proportion of patients. And this is what we meant by the progressive pulmonary fibrosis. And the next 20 minutes, I will try to share with you the terminology of progressive phenotypes in non-IPF ILDs, popularization of the term PF ILDs or progressive fibrosing ILDs as was defined in the inbuilt trial, then the definition of PPF that came out in 2022, then the various ILDs that manifest as progressive pulmonary fibrosis, and finally the role of antifibrotics in non-IPF ILDs with PPF, the evidence as well as recommendations. So if you ask ourselves as to what is known and what is unknown regarding PF-ILDs, before 2020, what was very clearly known was that there was a subgroup of ILDs, non-IPF ILDs, where there are some common pathogenetic mechanisms resulting in a self-sustainable and progressive fibrosis characterized by rapid progression of symptoms, lung function, quality of life, and even longevity. What was not very clear was the markers and predictors of disease progression and fibrosis, the role of immunosuppression and antifibrotics, and then studies that focused on patient-centered outcomes and addressing within group heterogeneity. So the research need was spelled out with the knowns as well as the unknowns. So what exactly leads to this self-sustaining fibrosis is not very clear, but it could be a genetic susceptibility. It could be a persistent trigger which we are either realizing or addressing, or persistent infections, gastroesophageal reflux, and of course the short telomere that is very gaining much popularity in the last few years. So the term PF-ILD, before the PPF came, the terminology was PF-ILD or the progressive fibrosing interstitial lung disease. This term was popularized by the publication of the inbuilt trial, because the inbuilt trial spelled out some objective criteria, that is worsening symptoms, lung function, fibrosis, etc., which occurs despite a standard treatment over 2 years or 24 months. That was the terminology that was used in the inbuilt trial. However, the term was useful because it allowed actually grouping of various clinical phenotypes in various etiologies of ILD into one common basket. And this common basket laid down objective and uniform diagnostic criteria. And that way it helped in clinical as well as research and therapy. Because rather than finding out drugs for fibrosis in each and every etiology, if this common terminology is there, they can be grouped into one heading and a large trial can be conducted. That was what inbuilt trial was actually achieving. From there, we went to the 2022 guideline update of where they defined the PPF or the progressive pulmonary fibrosis in non-IPF ILDs. So defining progression can be done by worsening respiratory symptoms, physiological progression, and radiological disease progression. So the time criteria that was put in this particular guideline update was 1 year, and there should be no alternate explanation for this worsening of symptoms or lung function or radiological worsening. So this was the objective criteria. Symptoms, of course, is self-explanatory. So in a patient with ILD of known or unknown etiology other than IPF, if he has radiological evidence of pulmonary fibrosis, if 2 out of the 3, that is worsening respiratory symptoms or worsening physiology, so that means an absolute decline of FVC of more than 5% over 1 year follow-up, or an absolute decline of DLC of more than 10% on 1 year follow-up, or radiological worsening. So the criteria also are prescribed, which are the radiological fibrotic worsenings, including the extent of traction bronchiectasis, new ground glass opacity with traction bronchiectasis, new fine reticulation, increased honeycombing, etc., etc. So the alternate causes of worsening that probably needs to be ruled out in a practical scenario would be acute lung infections, a cardiac failure, development of pulmonary hypertension, development of a pneumothorax, pulmonary embolism, alveolar hemorrhage, drug toxicity, etc., which again can cause worsening of symptoms, lung shadows, lung functions, or even oxygenation. So these things need to be ruled out before we make a label of progressive pulmonary fibrosis. Now, if you look at the inbuilt criteria versus the 2022 guideline update criteria, there are some differences because the inbuilt criteria required a follow-up of 2 years, which probably is too long, whereas the 2022 guidelines used a follow-up time of 1 year. So even 1 year is maybe high in some patients, as we will discuss in our panel. And secondly, The inbuilt used the criteria of relative decline of FVC, whereas the PPF criteria use the absolute decline in FVC, which actually are slightly different. And again, inbuilt criteria used, the PPF criteria used the absolute decline on DLCO also to the diagnostic criteria of physiological worsening, whereas this DLCO criteria was not kept in various trials, including the inbuilt. And again, inbuilt doesn't provide specific guidance on which is radiological worsening, but the PPF clearly gives guidance on what should be termed as radiologically worsening fibrosis. So these are the differences between these two things. And why was a diagnostic criteria of 5% or 10% or something like that kept in the various trials? Because we know that the mortality risk in IPF, which is a classical progressive fibrotic disease, it was seen that decline of 10% annually of FVC or occurrence of an exacerbation are very strong predictors of poor outcomes, including mortality. That is why the fixed cutoff of FVC of 10% has been kept. And again, one thing that we have to remember is that the annual decline in FVC may not be constant over the years. There may be patients who have rapid worsening in the first year, but in the subsequent years, there may be a slow worsening, and even vice versa, slow worsening in the first year and rapid worsening thereafter. So this all temporal heterogeneity has to be taken into account when we make a definition, but we cannot account for each and every clinical scenario. That is why this diagnostic criteria are being kept. So the next question comes. So we have understood that there are a subgroup of non-IPF ILDs which have progressive fibrosis. We made a definition, the first inbuilt criteria, and then with the 2022 update, we have the PPF criteria that have been spelled out. So which are the non-IPF ILDs that progress and to what extent? So IPF is not grouped into this because IPF is a prototype progressive ILD, even with treatment or without treatment. But progression also occurs in a subgroup of CTD ILDs, sarcoidosis, occupational ILDs, chronic HP, idiopathic NSIP, etc., etc. So the relative proportion varies. The guideline update itself mentioned the rough proportion of patients who progress in each of these subtypes of ILD. But as a general rule, the percent varies. If you look at some of the specific studies, in fibrotic HP, around 31% progressed in one particular study. Idiopathic NSIP is up to 60% progress. CTD related around 40% progress. And undifferentiated CTDs around 50% progress. But again, it has to be remembered that these are not magic numbers. Each patient is unique, and whether he or she will progress, we can tell only by longitudinal follow-ups. The risk factors for progression include patient factors like elderly, male sex, presence of autoantibodies, short telomere, etc. Radiological factors like extent of fibrosis or extent of ILD more than 20%, the presence of traction bronchiectasis, and a radiological UIP pattern. The baseline physiology, if the patient has a low baseline FVC or DLCO, that itself is a risk factor for progression. And lack of a response to initial treatment, lack of prompt stabilization is also a risk factor for progression. So once you come to the therapy of PPF, it again depends upon the etiology. You have to institute treatment that is specific to that particular etiology of pulmonary ILD. But as a general rule, since these patients have a progressive fibrosis, these are candidates for therapy with antifibrotic agents. So the one that is maximum evidence will be nintedanib. So the inbuilt study is the prototype or the landmark study which established the role of nintedanib, the benefit of nintedanib in patients with progressing PF ILDs. So this was a placebo-controlled multicenter RCT of patients with ILD involving more than 10% of the lung volumes and progressive fibrosis over the last 24 months, around 600 patients. So that's a large number. And the primary outcome was the annual rate of FVC decline. It was seen that the FVC decline between placebo versus nintedanib, the difference itself was around 107 ml. So that was a huge magnitude of difference. And the difference was even more impressive if the patient had a baseline UIP pattern. So the difference was almost 127 ml annual decline for preservation of annual decline if the patient had a UIP pattern. And Again, if you see other secondary endpoints, even the exacerbations, death, all those things had numerical improvements, but this improvement didn't reach statistical significant values. A lot of adverse events, especially diarrhea and nausea, but not severe enough to discontinue treatment or cause or not labeled as a major side effects. Even weight loss occurs because of this diarrhea, poor appetite, and all those things. So that much about the nintedanib. That's the landmark trial. There are other trials also which we will discuss, or rather meta-analysis which we will discuss during the panel discussion. If you look at the trials on pirfenidone on PPF or PF-ILDs, the general comments are that we have two RCTs, the RELIEF and the UILD trial, and a meta-analysis of these two trials, but small patient numbers in both of them. One of these trials was prematurely terminated, and generally the quality of evidence is considered low, and the confidence by which we can recommend pirfenidone for a PF-ILD is generally low, although most of us tend to use it in our day-to-day practice. So this was the RELIEF trial, which was a German study in around 17 centers. Multiple etiologies were studied, including CTD, chronic HP, etc., etc. And it was seen that there was an around 80 ml difference in FVC change, and even a difference in DLCO change with pirfenidone. However, it was seen that it looked clinically meaningful, but not statistically significant. And again, this was a very complicated statistical study design, so it's not very easy to infer conclusions from this RELIEF trial. And there was a premature termination after interim analysis because of slow recruitment and futility that was made after the interim analysis. The second one was the UILD trial. Again, it's a multicenter RCT of patients with unclassifiable progressive fibrotic ILDs, around again 663 patients. It was seen that there was significant difference in FVC decline. However, it was seen that the confidence intervals were too broad and extends from benefit range to harm range. So because of this, again, a very low quality recommendation was given for pirfenidone. So based on these two, I would say that nintedanib has a moderate quality of recommendation with to use in patients with PF-ILDs or PPF in non-IPF ILDs, whereas pirfenidone, it's not given a very clear-cut recommendation at all. The last thing on the block is something that is not available in India, but that has been just come out as a trial. That is a fibronid ILD trial, the drug that is nerandomilast. So this was again a phase 3 trial with a randomization of placebo and 2 doses of nerandomilast. Then the groups were stratified based on the background antifibrotic therapy, whether they received nintedanib or none. And again, the primary change was an absolute change of FVC at 1 year. It was seen that this particular study group had good representations from various subclasses of ILDs like CTD, HP, NSIP, etc. Almost 40% of them were using nintedanib, and 70% of them were having the UIP pattern. It was seen that the FVC fall of 165 was noted with placebo, 85 with various doses. 85 with the 9 milligram BD dose of nerandomilast, and 98 with the 80 milligram BD dose of nerandomilast. And FVC preservation occurs independent of background treatment with nintedanib or not. So that's a very value-added addition to our armamentarium for treating progressive pulmonary fibrosis in non-IPF ILDs, as well as there is a simultaneous study in IPF also, the fibronid IPF study, which also shows benefit with the nerandomilast. Again, lot of diarrheas, GI side effects are pretty common, and of almost 50% of the patients experience diarrhea if nerandomilast and nintedanib are combined. One more trial I will come to, that is the inhaled treprostinil and lung function in various ILDs. This was actually a post-hoc analysis of the INCREASE study, which actually demonstrated a benefit in 6-minute walk distance with treprostinil in various ILDs. Now, a post-hoc analysis actually said that there occurs an FVC improvement also in patients with various ILDs which are treated with treprostinil. This was a mixture of various cases, including IPF as well as non-IPF cases. So we don't really know whether these benefits extend across board for all non-IPF ILDs. Again, the acute exacerbations of progressive pulmonary fibrosis are also getting defined, just like the acute exacerbations of PPF. It was seen that around 25% of PPF patients experience acute exacerbations on a 5-year follow-up, and these exacerbations definitely contribute to more morbidity as well as premature mortality, as is very clearly evident in this particular graph. And these are some of the, other than the published trials, these are some of the landmark trials that are actually ongoing with regard to various RCTs in PPF. I'm not going to each and every one of this, but some LPA1 antagonists as well as the treprostinil are undergoing various phase 3 studies in PPF. The research priorities, we need to determine reasons and risk factors why a subset of patients with ILD of various etiologies going to the PPF phenotype. What are the risk factors and how can we prevent them? Secondly, we need to identify and validate various biomarkers to identify the risk of progression and development of progressive pulmonary fibrosis. And we also need to determine the ideal timing, ideal agent, and ideal sequence of antifibrotic drugs, especially in relation to other agents like corticosteroids and immunosuppressants that form a cornerstone of treatment, especially in CTD ILDs. So if I can conclude, PPF occurs in a subgroup of non-IPF ILDs. The 2022 guideline update has given diagnostic criteria based on the clinical, radiological, and physiological characteristics. Pharmacotherapy, nintedanib is given a conditional weak to medium recommendation. Pirfenidone is very promising but lacks quality evidence, so that way it is not given a very hard recommendation. Nerandomilast is a latest addition, probably might come into the guidelines subsequently. There are a lot of upcoming trials. We need to find endotypes, genomics, and maybe personalized treatment in many of these progressive fibrosing ILDs. So thank you, and I leave the baton back to Madam Thilagawathy.
Thank you, Dr. Rajesh. I think so many trials and so many this thing you walked us through in such a short time. It was crystal clear, structured, and pragmatic. Thank you very much. Very, very to the point. I'm also very eager to look at what our panelists are going to say regarding this progressive pulmonary fibrosis. So let's move on to the panel discussion. So let me introduce all the rest of our eminent panels here. Yeah, can you put their slide, ma? Dr. Yeah. So the first is Dr. Parul. She has so many distinguished accolades to her. She is an executive council member. She's a past president of SMCA, past president of IMA Surat, past IMA National Joint Secretary, past vice president IMA, executive council member in Gujarat University, Public Health Committee. She's professor and head of the Department of Tuberculosis and Chest Medicine in Government Medical College Surat. And I think she has a lot of achievements. She's also a chairman of National Working Group on Standards of TB Care in India. So she's, I think, stalwart in tuberculosis and plus rest of pulmonology. She has organized 87 multi-speciality camps, 25 hemoglobin screening camps, 50 health awareness seminars, adopted 280 malnourished patients of tuberculosis. Wonderful achievement. Thank you, madam, for being here today. We'll move on to the next panelist. This is Dr. Barney Isaac. He's professor and head Department of Pulmonary Medicine, CMC Vellore. And his area of interest is especially ILD, particularly sarcoidosis. And he's also interested in biostatistics, study designs, which is very rare among pulmonologists, exercise physiology, sleep disorder breathing, interventional pulmonology, and he has authored book chapters and presented in conferences also. He has received the Young Scientist Award in NAPCON in 2008 and Best SAS Trainer Award. Congratulations, doctor, and welcome to the panel. Let me introduce the next panelist, Dr. G Mullerpattan. He is a consultant chest physician in Hinduja National Hospital. He has special interest in ILD and in severe asthma and MDR tuberculosis. He's got over 20 national and international publications. He's a ERS Silver. He has received the ERS Silver sponsorship in 2016 and Best Abstract at NAPCON in 2016. He's also a member of ERS, ICS, and he is got a fellowship of ACCP. Thank you for being here, doctor. Welcome to the panel. Let me move on to the next panelist, Dr. Rahul Sharma. He's hailing from Noida. He's a additional director, pulmonology and critical care in the Department of Pulmonology Critical Care in Fortis Hospital in Noida. He's a DM Gold Medalist, Young Investigator. He's received the Young Investigator Award from ICMR in 2014. Also, a Young Investigator Travel Award from ICS in 2019. He has more than 40 publications and 3 book chapters in peer-reviewed national and international journals. Thank you, Dr. Rahul, for being here. I think we have such eminent panel, and I'm looking forward to a great discussion on PPF. This is going to be, a go-to session where practically day-to-day matters we are going to discuss, not sticking to theoretical explanations. So let's move on to the...
Before Madam moves, it's our privilege to introduce Madam also. You have been the backbone of today's webinar, Madam. So, Madam Thilagawathy, she hails from Chennai. She is the HOD and Senior Consultant in Respiratory and Sleep Medicine at the prestigious Vijaya Group of Hospitals in Chennai. And I have been fortunate enough to visit that during NAPCON 2013, if I'm not mistaken, Madam. And achievements, she is a treasurer and co-founder, Association of Women in Pulmonology, and she is also the associate editor of the Pulmonary Disorders in Women textbook, which is very well appreciated and has a wide circulation. She's a faculty in various national and state conferences, including the NAPCON, TAPCON, etc. Member of the National Board of Sleep Medicine Fellowships and awarded Inspirer in Pulmonary Medicine 2023 by the ICS. The very, very true pick, Madam, and publication, very notable publications on rare lung diseases. Tracheal bronchostalcosis and pulmonary maltoma. So, Madam, we have anchored our program till now, and welcome to continue the same thing, Madam.
Thank you, Dr. Rajesh. So let's move on to a discussion. So the first question I'm going to ask Dr. Parul, though we have listened to Dr. Rajesh, who has given us a very good explanation on everything about the ATS paper, still for the people who have joined late, or for everybody to understand the definition of PPF, I think this message needs to be clear in whom you should diagnose PPF. How do you define progressive pulmonary fibrosis according to the ATS, ERS and ALAT 2022 guideline? Just give us a crisp summary of what is the definition all about. Dr. Parul?
Yes, madam. Thank you so much. Though Rajesh sir has given us in detail, but if we define it progressive pulmonary fibrosis very clearly, according to 2022 ATS /ERS Japanese Research Society guidelines, all guidelines, which tell us that at least 2 of the following 3 criteria, means either worsening of the respiratory symptoms, radiological progression of the fibrosis, which can be in form of increase in the reticulation, increase in traction bronchiectasis or honeycombing, and third point is physiological progression, means decline in the lung function, which is absolute decline of FVC by 5% in last 1 year, and absolute decline in the DLCO by more than 10% predicted when we correct it for hemoglobin. So these are the 3 criteria, and out of these, in past year, means past 1 year, we have to see if 2 criteria are positive and there is no alternative explanation for any other disease, like maybe infection, maybe heart failure, maybe pulmonary embolism or any other cause or heart failure. So in that case, we can stamp the patient as progressive pulmonary fibrosis. So we have to look for the past 1 year history. We have to look for criteria, symptoms, as well as rule out other diseases, as well as we have to do the pulmonary function test and DLCO. So all these things together makes us confident about the diagnosis of progressive pulmonary fibrosis according to 2022 recent guidelines, madam.
Thank you for the clear, crisp definition. I think everybody would have got the message. As Dr. Rajesh also stressed, there are 4 important components to this definition. He explained it so clearly, and she has also explained clearly. So don't forget, these are non-IPF patients, and you need to assess for 1 year, and you should not have an alternative explanation for the deterioration. So that's very important. You cannot have a pulmonary edema patient. You cannot label them as progressive pulmonary fibrosis. And as she rightly said, we need to concentrate on the three main domains, which is clinical, physiological, and radiological. I think this message is clear. So we'll move on to our next panelist, Dr. Barney Isaac. So what percentage of non-IPF ILD show the progressive phenotype? I think Dr. Rajesh has explained, but still make it clear. And which ILDs constitute this cohort percentage-wise?
Right. Thank you, madam, for that very important question. I think we all know that IPF progresses, but when we come to the non-IPF, it's not, we know that everyone doesn't progress. But a proportion of each of these subsets do progress. A ballpark figure, if you combine all non-IPF ILD, it's about a quarter to a third of patients will progress at some point in their follow-up. Now, the literature is a range of each of these subsets in various countries and continents is very variable, the range. But however, we know that certain diseases like fibrotic HP, I'll stick to the old terminology not to confuse, fibrotic HP, certain CTD ILDs like RA ILD, scleroderma ILD, particularly if they have a UIP phenotype, are all likely to progress in higher proportions. That's about 40%. And I think one study, Dr. Rajesh mentioned that idiopathic fibrotic NSIP was up to 60%. So these are the ones that are a larger chunk progress. Then the other SLE ILD and say organizing pneumonia, sarcoidosis, some of these other middle ones progress in about 20% on an average. And the rest of the ILDs progress only about 5 to 10% of them progress. So that is kind of a range at which non-IPF ILDs progress.
Thank you very much for that crisp, comprehensive answer. This is exactly what the audience should take home. So approximately what he said is right. 1 in 4 of our non-IPF patients behave like IPF. Why we are talking about all this today is we need to spot them early. Why do we need to spot them early? We will have a panel discussion later for the questions. We'll move on to the next panelist, Dr. Jai. What is this subgroup? Why is this subgroup clinically relevant, especially from the treatment and the survival probability with respect to non-PPF?
So basically, we know that patients who are progressive, they have a poorer prognosis long term. There have been studies which show that even at 1 year, the mortality, there's almost a 6% difference in mortality between the ILDs that progress versus those that don't progress, which goes up to almost 20% difference at 3 to 5 years. So identifying patients who do progress, and one is treating them adequately as well as then early initiation of antifibrotics would be helpful in these kind of patients, as well as, of course, listing them for lung transplant, etc.
Thank you. That was wonderful. So the thing about this is most of our PPF patients, like pulmonary fibrosis, we diagnose when the patient is late in the disease. So already they would have wasted like 1 year before coming to us. So there is a need to differentiate between PPF at first presentation with worsening symptoms and worsening imaging and everything, and PPF occurring despite optimal management. So the clinicians need to distinguish these three, and you should find the right cohort of patients where you're going to put the antifibrotic. This distinction is really critical in clinical practice. There is no free for all prescription for all it's not a blanket treatment across for all fibrosis. So then the approach becomes chaotic. So today's discussion will make things clear for everybody when they practice. So we will move on to the next panelist, Dr. Rahul. Tell us about what radiological determinants constitutes and what does not constitute a fibrosis. So not everything is labeled as fibrosis, and which fibrosis are important when you see a CT chest.
Absolutely. I think I must congratulate ICS and Dr. Nene for this wonderful seminar and this relevant topic of clinical importance rather than theoretical part. As far as the fibrosis is concerned, anything which is causing scar in the lung is fibrosis. But when we are talking about ILD related fibrosis, there has to be some pattern associated with this. So fibrosis can be in terms of reticulation, which is basically linear opacity with thickened interlobular and intralobular septas, traction bronchiectasis or bronchial ectasis, which is irregular dilatation of bronchi, bronchioles, which is going up to the peripheries. There has to be associated architectural distortion, which is basically displacing the other part of bronchi, vessel, and fissures, and septas due to scarring. And the most common or the most striking feature that we see is honeycombing, which is basically stacking of cystic air space, which is around 2 to 10 mm. Sometimes it may increase, and usually subpleural and basal, which is pathognomic of fibrosis. And all these things leads to volume loss. When these things are coming in a pattern, then you say that it is related to ILD, because you can see fibrosis post-tubercular, post-infection, and there are other causes to this, like ABPA and other things. So it has to be in some kind of pattern, like the pattern is defined for IPF, subpleural, basal, honeycombing, traction bronchiectasis. So the pattern has to be very, very important, rather than focal finding of fibrosis does not constitute it to ILD. And we need to be very, very careful that what we should not include in ILDs. And I think IPF has defined, ATS criteria has defined it very well. So if there is a ground glass opacity, which is not associated with traction bronchiectasis or other fibrotic part, then this is probably not fibrotic. But if it is associated with traction bronchiectasis or other fibrotic features, it can or may or may not be fibrosis. So that is the one thing, that ground glass opacity has to be seen in a very important term, as we are talking about progressive fibrosis. Probably these ground glassings is going to change into fibrosis if your patient is going to behave like a progressive fibrosis thing. So ground glass opacities are very, very important to define whether it is fitting into fibrotic classification or non-fibrotic classification. If you have superimposed consolidation in terms of infection, central lobular opacity, striatum bud, all these things reflect only infections, or there is some atelectasis, mosaic attenuation, air trapping not associated with other features of ILD. Like we do see mosaic attenuation and air trapping with the hypersensitivity pneumonitis, but there are other features of fibrosis also associated with this. And if there are pleural thickening and effusion, these are not the part of fibrosis. So it is not only fibrosis that we need to see the pattern and spread of fibrosis to identify or narrow down our differential diagnosis for ILD evaluation.
Thank you, doctor, for that refreshing and practical perspective. You have given valid points regarding GGOs. So the point about fibrosis is, if there is fibrosis, think of reticulation, think of traction bronchiectasis or traction bronchiolectasis and honeycombing. Beyond that, I think GGOs have a variable approach. So we will ask our next panelist, Dr. Rajesh. So exactly what he has described. Now, what constitutes progression and what other conditions should you be differentiating it? A GGO can occur with a viral pneumonia, can occur with a pulmonary edema, can occur with anything. So what are the mimics we are going to rule out here when the patient has progressive pulmonary fibrosis? Dr. Rajesh?
Madam, thank you, madam. And again, very, very clinically oriented question there. As all of us would agree, the most important thing that the patient comes to us would be with a worsening symptom, that is classically a worsening shortness of breath and then a worsening cough. So when that happens, we evaluate the patient first with radiology, usually in our clinical practice. So if it shows a worsening lung shadows, if the patient is not that sick enough, we might do a lung function also, if that might show a worsening. So I think here a clinical evaluation and interpretation of this results in a clinical background is very important. So as you very correctly said, acute infections are events that actually can worsen all these things, symptoms, worsening lung shadows, as well as worsening gas exchange and lung functions. So maybe viral pneumonias, even bacterial pneumonias, if it is subacute, even tuberculosis, because especially CTD and all those things, many of them would be on immunosuppressions. Secondly, cardiac failure, because cardiac failure with interstitial edema is always a differential diagnosis. There may be smooth reticulation and all those things, bilateral pleural effusion. So the clinical factors, as well as some radiology, might help to differentiate. Pulmonary hypertension, because many of these ILDs are associated with pulmonary hypertension, again, it contributes to worsening shortness of breath. There may be some worsening of ground glassing just because of the pulmonary hypertension, the basic attenuation, and all those things. We might need to do an echo and even sometimes a cardiac catheterization if you are very doubtful. Then pneumothorax, because many of these cysts, honeycomb cysts can rupture and sudden shortness of breath can occur, but that's easily differentiated in a chest radiograph, physical examination chest radiograph, plus or minus a CT if there is a major doubt on that. Pulmonary embolism, again, leads to worsening of shortness of breath and gas exchange without worsening of many other parameters, including the lung shadows. Worsening lung shadows may not be there. You need a CT pulmonary angiogram if there are risk factors and your clinical assessment says so. Some of these diseases, especially CTD-related ILDs like SLE, can have an alveolar hemorrhage, so there may be a sudden worsening of shortness of breath and worsening of alveolar shadows. You might have to exercise your clinical acumen as to whether the patient is having hemoptysis, whether you should go ahead and there's a HP drop, and you have to go ahead and do a bronchoscopy and see for serial lavages and look at the X-ray, the effluent and all those things. And finally, some of the drugs that can be used for the CTD per se or any associated conditions like the cardiovascular conditions or an associated malignancy, all those things can have a drug toxicity and can cause worsening of all these things. So all these things have to be evaluated in a clinical plus or minus targeted investigation context to rule out mimic of PPF.
Thank you. That's very, very interactive contribution. I think here you have made a very valid point that there is no one size fits all here. So one patient may present with viral ARDS, the other patient will have a pneumonia and present, the other patient completely different. They can have comorbids, they can come with cardiac failure, severe LV dysfunction, coronary artery disease, and renal failure. So many other issues can be there. So we should remember here that no patient walks out of the textbook and says, I am having only PPF. Doesn't happen like that. So clearly there is no one size fits all. So it is this is actually precision medicine, and to the patient, involving the history, the clinical examination, appropriate investigations, you have to tailor the treatment to this patients. Okay, let's move on to the next panelist, Dr. Parul. Physiologically, we have discussed the physiologic domain, saying that there are absolute criterion for progression, like, FVC criterion and the DLCO criteria. So how often do you do these tests? How often should be done? How often do you repeat these tests in your practice?
Yes. If we talk about FVC, as we have already discussed, it is like more than 5% of the decline in last 1 year. It is positive criteria. And DLCO more than 10% in last 1 year, along with the corrected for hemoglobin. So that is important, which we have already discussed. If we talk about PFTs, madam, we have to repeat it every 3 to 6 months. The criteria is 3 to 6 months, but according to the patient follow-up or improvement, we can repeat it every 6 months also. We talk of DLCO, it is better to repeat the DLCO every 6 months. And according to the need of the patient, we can repeat it frequently also. And PFTs and DLCO both should be aggressively, PFT especially should be done aggressively every 3 months in 1 to 2 years, initial 1 to 2 years. As such, 6-minute walk test should be done at every visit and at every assessment whenever we do the clinical assessment. And all these tests should be can be frequently made according to the clinical deterioration or progression of the patient. It is not a thumb rule, but PFT 3 months, DLCO 6 months, and 6-minute walk test every visit. That is the criteria to follow up the patient physiologically. And especially when there is a decline in the FVC more than 10%, it is again it's an important prognostic criteria for mortality. So FVC, if more than 10% decline in last 1 year, we have to think that patient mortality may be high in future. So that is again one of the prognostic validation if FVC is more than 10% decline. So criteria is more than 5% and DLCO more than 10%, but FVC getting more than 10% is a prognostic mortality criteria. So this is how frequently we should do PFT, DLCO, and 6-minute walk test.
Thank you. That was crystal clear. Okay, so she has made a point that you should think of PFTs and 6-minute walk tests like ECG in cardiology. frequent, cheap, low risk. CTs definitely are your power shots, but play them wisely. So you need to do 6-minute walk test at each visit whenever the patient comes. But you need to do the PFTs, maybe spirometry or DLCO every 3 to 4 months. So then that brings us to the next question. She has discussed the physiological domain. We'll move on to the radiological domain. We will ask Dr. Barney, radiologically, what are the criteria for progression and how frequently CTs should be done to keep this pulmonary progressive PPF in mind.
Thank you, ma'am. Just one point to add
on the radiation exposure a bit.
Sure. So one just additional point to the walk test. Now in CTD ILD, we need to be a bit cautious about using walk test because the walk distance is affected by non-ILD factors. So it's not a best test for follow-up. And also walk test doesn't determine from PPF point of view, it gives very limited information. Sometimes it helps to rule out other coexisting illnesses. Coming to radiology, I think Dr. Rahul has clearly mentioned all the criterion. So if I can just put it in a gist, if we start with gross volume loss to gross honeycombing to traction bronchiectasis to reticulation, any of this increasing or newly appearing is a problem. If any of these factors is there, it would amount to considering PPF. Now, the subtle thing is the ground glassing, which has in areas where there are traction bronchiectasis, which again, Dr. Rahul has very clearly explained. I'm not going into it. But now that we are also aware of PPF and we have these following up on treatment, these non-PPF ILDs, there is a tendency to repeat CT to see what's going on. But actually, we need to be cautious there because as we discussed, only 1/4 will probably develop PPF and they will develop symptoms and lung function impairment without which there is not going to be radiological progression. That is why the PPF criteria has at least 2 out of the 3 clinical, physiological, and radiological. And radiation exposure is an important risk. And we need not do CT routinely in patients with non-IPF whom we are following up. If they are improving on treatment, if they're stable when we taper treatment, there is no need to do a radiological cross-sectional imaging. So in other words, if you have to sum it up, it has to be individual, case-based. When there is symptomatic progression and or physiological decline, we do an imaging to see what is the reason for the decline, and then we will be able to diagnose PPF if it fits into that criteria.
Thank you. Thank you for that answer. I think he has made a very valid point. So if you have worsening respiratory symptoms, which is one domain, and then your PFT or spirometer is normal, but still your patient is symptomatic, then go ahead with CT scan. Do not do CT upfront in everybody and then don't use it as a blanket treatment. Sometimes I think everybody will, in our clinical practice, we'll see that CT speaks louder than the spirometer. So you need to identify that cohort of patients. Don't just do CT for everybody. We should keep radiation exposure also in mind. So maybe in a patient who's progressing on a case-by-case basis, as he rightly pointed out, you can do a CT chest. So we'll move on to Dr. Jai. So the criteria, there are 3 domains in our PPF criteria, which say that you have 2 out of the 3 domains, and for over a 1-year period, if they progress, then that is called progressive pulmonary fibrosis. So suppose you have somebody, should we wait for 1 full year of observation before labeling a patient as PPF, or can progression be diagnosed earlier itself? Dr. Jai?
So it depends on a case-to-case basis. We would look at the patient clinically. If the patient has worsened in the last 3 months, you will not wait for a year. Obviously, you you'll you'll investigate them earlier, maybe get a PFT done, and if needed, even get a CT done, or rule out other causes of breathlessness with an ECG or echo, etc. So it would depend on the clinical condition of the patient. If the patient is stable, on your 6-minute walk test as well as symptomatically, then maybe you can wait for a year before ruling out progression. But there is if there is clinical worsening, definitely we can diagnose it even earlier, whether it's 3 months or 6 months.
Thank you very much. So that brings us to one important point. You need to know that there is an entity called rapidly progressing ILD. So in anti-MDA5 positive patients, they can progress within weeks to months. So you don't have to wait for this criteria, and their mortality is 50%. So please, when a patient who is progressing, please do the initial workup thoroughly to diagnose properly, to rule out these group of patients, because at the time you diagnose anti-MDA5 in the ICU, you should be listing them for transplant. So there is an entity called rapidly progressing ILD. As sir rightly mentioned, we should take it as a case-by-case basis before we decide. So moving on to the next panelist, Dr. Rahul. So adding to the question, I think earlier the panelists were talking about probability of survival between progressive and non-progressive variants. So can we even comment on the survival depending on which criteria of progression can we comment on this? So with respect to, there are some South Korean studies and things like that. So what is your take on that, Dr. Rahul?
I think the first thing that we need to understand that not all ILDs are progressing that fast. One, the ILD which is progressing fast, you cannot quantify that which ILD is going to progress fast and which is not. So criteria is just to define progression. But when we look into these criteria, all of them has a determinant which is physiological, radiological, and symptomatic. And the scoring study and the other study even before that has identified that the most important criteria to define progression or even mortality is the physiological criteria, which is fall in FVC more than 10% or DLCO more than 15%, followed by radiological criteria. But when we look into the clinical practice, we are not going to do the PFT every now and then in our patient until the patient is symptomatic. So when you look into the criteria, it is a little paradox that these are defining and the mortality is defined by FVC. But I think we will pick up these patients only by symptoms. If the patient will not have symptoms or the symptoms are not progressing, probably I'll not do PFT or CT of my patient to look for the progression unless it is 1 year past. So I think you need to see the patient wholesome. Criteria is just to define the progression. The criteria needs to be understand in the clinical scenario where the most important parameter is the decline in lung function, which is associated with symptoms, although symptoms can be varied in terms of infection or other comorbidities which can be associated with this. But yes, per se, going by any criteria, if you are able to pick up progression of the disease, then you can do better, optimization of your patient rather than just sticking to any one criteria defining the mortality.
Yeah, right. So if it smells like IPF, if it smells like PPF, if it walks like PPF, don't wait for 1 year. And even diagnosis in 6 months. That's what the panelists are trying to say. So you should be aware that you can detect progression earlier also, and then be aware of that, and also individualize your patient. Not, it's not for everybody. If you're very convinced that this patient is progressing in 6 months, act early. So then we'll move on to our next panelist, Dr. Rajesh. So actually we have seen that PPF is a cohort of various, connective tissue disease, hypersensitive pneumonitis, sarcoidosis, whatever ILD which progresses, we have grouped into that category we saw in the talk today. So if your patient of HP is misdiagnosed as IPF and is being treated that way with ongoing obvious antigen exposure, and if there is clinical and physiological worsening, then will you label the patient as PPF and will start antifibrotics, or what you will do?
It's a bit of a tricky question, madam. I don't think there will be a one correct answer for that particular scenario. You look at it this way: if you are a very innocent, sort of puristic clinician, then you can always believe that yes, my patient had a HP, antigen trigger was not looked at. Now I have discovered it. Now the exposure is taken care of. So probably it may not progress since the antigen exposure is stopped. So I may not give antifibrotics. That's one way of thinking. Whereas if you are a contradicting skeptic, you can always think that you have missed the antigen exposure. So the patient has gone into criteria of fibrosis, both physiologically as well as radiologically. So even if the antigen exposure is stopped there may be some self-exponential inflammation which lead to self-sustaining fibrosis even after antigen exposure. That's a feasibility. So you can even think of giving antifibrotics in that particular fashion. Having said that, if you look at the inbuilt trial data a bit more carefully, a couple of things that come out will be that the subgroup of patients who had the minimum improvement in FVC was those with fibrotic sarcoidosis and fibrotic HP. So they don't do that well in that subgroup of patients. This was evaluated in a subsequent post-hoc analysis. The Lancet 2020 paper said that still, even in fibrotic HP, the improvement is meaningful. Whereas one meta-analysis subsequently said that probably in fibrotic HP, it's not that meaningful. But that is the author's take. I feel the magnitude of benefit definitely occurs, but not to the tune of what we see in CTD or other things. Having said that, the final word from my side would be that there are a couple of small trials, not very huge like the inbuilt or impulses or something like that. One in thorax 2023 on pirfenidone in chronic HP, and one in respiratory research 2025 on nintedanib and pirfenidone in chronic HP, around 150 patients each. Both of them said that antifibrotics are beneficial even in fibrotic HPs. So it's an anybody's take at this particular moment of time. I would probably err on the safer side if antifibrotics are tolerated and safe in this subgroup of patients.
Yeah, thank you very much for that answer. I think that's the most important point here is you need to categorize your patient or identify what is the primary problem which is driving the patient to progression. So if you are having HP, you should treat optimize your treatment on the basic diagnosis. So you need to get to the diagnosis. If it is HP, tailor your treatment according to the guidelines to HP. If it is sarcoidosis, please remember to tailor your treatment, immunosuppressive treatment. Some patients with sarcoidosis, if you remove the steroids, they will immediately show a decline in FVC. So you need to identify and optimize the primary treatment. That is what this guidelines is all about. You need to optimize their primary problem according to that particular disease guidelines. And then if still they progress, then you can take a call and then add an antifibrotic. There are situations where you can add an antifibrotic at the time of diagnosis. That is only reserved for a few conditions. I think one is if you have rheumatoid arthritis and UIP pattern, you can start antifibrotic upfront. And the other is if you have IPF diagnosis. The other is, I think if there is in the census trial, scleroderma. If you have scleroderma ILD which is progressing, you need not wait for the diagnosis. The time you make a diagnosis, you can add an antifibrotic. And also the most important here is anti-CCP titers also matter. If the titers are high, you need not go through all the definitions and then wait for 1 year. Upfront, you can start antifibrotic. Barring these scenarios, you need to demonstrate a progression. You need to follow your patients, and then only there is indication for antifibrotics. So we'll move on to the next part of the discussion. So Dr. Parul, if CT shows honeycombing in a patient with CTD ILD who has not been treated for CTD ILD, should we still start antifibrotics upfront? This is just a continuation of the previous.
Yeah, this is rather a continuation of what you discussed, ma'am. See, basically, as it is already discussed, that antifibrotics are not first line treatment. First line treatment is suppressing giving the immunosuppressants, treating the primary cause, treating the causal, basically the causal factor. And then if the patient is not improving with the immunosuppressants, then you you can think of adding on the antifibrotic, especially in the condition of scleroderma, in which there is already madam has already mentioned the census trial, which has proven that in scleroderma related means systemic sclerosis associated ILD, you can definitely think of adding the antifibrotic agent along with means on day one also, along with the immunosuppressants. But especially also in rheumatoid arthritis also you can add. But other conditions, other collagen vascular disease, other CTD associated ILDs, first you should do start with the immunosuppressants. In certain conditions where patient cannot tolerate immunosuppressant, there is some contraindication, or these are 2-3 conditions where you can definitely go for antifibrotic agents on in the initial basis. Otherwise, treating the causal factor, treating the disease, treating the primary cause is most important, rather than going upfront for antifibrotic agents in the CTD related ILD, especially where there is honeycombing and not previously treated patients.
Thank you. So the basic message here is treat the disease and the antifibrotic when it still moves on. So always fix the leaking tap before replacing the whole pipe. That's the message. We'll move on to our next panelist, Dr. Barney. Can you take us through the pirfenidone trials and its current state and role?
Thank you, ma'am. So pirfenidone has unfortunately taken a back seat in the treatment of PPF. I think it came on late, so trials started only as late as 2016, 17, 18. And after the initial small number trials, the main trial was the UILD trial, which was discussed, which was by Dr. Toby Mayer et al. That was published around 2020. The problem was the inclusion criteria there was unclassifiable ILD, who had progression, and the benefit was very borderline. Then came the relief trial, which is often spoken about, but the relief trial had very stringent criteria. It had all the subcategories, CTD-ILD, idiopathic fibrotic NSIP, fibrotic HP, and all that. But because of the stringent criteria, they aimed for 550 patients or so, only about 36% recruitment. So it again did not had very borderline outcome measures in a complicated analysis. So that left things lingering. The only other study which came up is there have been about 3 scleroderma lung disease studies, 1, 2, and 3, which are looking at combination therapy for scleroderma ILD. So the SLS3 study actually looked at mycophenolate with placebo and mycophenolate with pirfenidone in scleroderma ILD. Unfortunately, this started little before COVID, and COVID struck, and because of that, the numbers could not be recruited. So because of all these disadvantages, the overall outcome of pirfenidone in PPF has been sparse, low numbered, not very attractive. So as of today, it's still not an FDA approved drug for PPF and remains to be off-label therapy.
Thank you. So I think if they had not stopped the trial with pirfenidone early, if they had continued to recruit more patients, because of COVID they stopped, I think we would have had an answer for that now. So still we don't have an answer, but still I think pirfenidone is a it's like a cameo star in PPF. It is promising, but it's not the lead. Okay. Next, we'll move on to Dr. J. Speaking of nintedanib, it appears as the most promising drug. Can you elaborate why it is such a promising drug? Already, the speaker has told about the various trials. Just give us an insight into that.
So basically, we had one disease-specific trial, that the census trial in specifically scleroderma ILD, as well as the inbuilt trial, which took a broad group of PPF patients, and in both the trials, it did show significant difference and a reduction in the drop in FVC compared to placebo, and so that probably is the one drug which has the most robust data regarding efficacy in PPF patients. And we've seen in the inbuilt trial the difference that the protective value of nintedanib increased in the patients who had a UIP pattern compared to a non-UIP pattern. Although the absolute values were similar, but compared to placebo, it was almost about 82 compared to 200 in the UIP group and about 80 ml to about 150 ml in the non-UIP group. So if you have UIP, you are probably more likely to benefit from nintedanib and maybe more urgent use of nintedanib in those patients of PPF. And although the meta-analysis, there was some confusion about whether it would work in fibrotic HP, etc. Although in the inbuilt trial, it did show that it might work. So maybe specific trials targeting fibrotic HP might be required in the future.
Very true, very true. Okay, so it's actually nintedanib is one drug. There are many ILDs. Definitely the slope flattens. So that's why it is approved for across the board for all the PPF ILDs. So Dr. Rahul, can you, actually we have talked about the census trial. Please give your views. What about the census trial and how it helps in PPF?
Absolutely, ma'am. I think I will just add one comment to the last question. Why nintedanib is preferred? Because it has a potential to prevent exacerbation, or rather in exacerbation, it has been shown that it is going to decrease the future exacerbation. And the popularity again is because of tolerance, which is way better than pirfenidone. These are the 2 points that makes the gain of this, the popularity of nintedanib very high. And this trial on systemic sclerosis, the census trial, they have opened the opportunity to utilize this drug in non-IPF. Before that, antifibrotic was strictly for IPF, but when this trial came, I think this has opened up the wide spectrum of these ILDs to be tried with nintedanib alone, or in combination, or in the later part, or when the progression is there. So this trial is one of the very important trial as far as the non-IPF ILDs are concerned, in which I think more than 500 patients were evaluated with nintedanib, and mind you, 50% of these patients was on mycophenolate mofetil. And this trial has shown even patients on mofetil, if you add pirfenidone, as you rightly highlighted, then the decline of lung function are even slower. So this is the outcome of this study, that in non-IPF group, even from the beginning, you can start nintedanib, especially in systemic sclerosis, to slow down the progression of disease, rather than as an end-stage disease when we have no other option but to try these antifibrotic before bridging these patients for lung transplant.
Thank you very much. I think that's a clear message to all of you that nintedanib can be safely used with MMF, and it has got addictive effect. It can prevent exacerbations. It can slow the decline of FVC, and it also, it prevents exacerbation, slow the decline, and it has an additive effect on the progression, delays the progression of PPF. So let's move on to the next panelist, Dr. Rajesh. So I think the speaker also mentioned about a meta-analysis on nintedanib, which gave a cautious note on limitations and efficacy in subtypes. Though a decrease in FVC decline was significant, what is the status of further studies with nintedanib in various ILD subtypes? Dr. Rajesh?
Yes, ma'am. As you correctly pointed out, that meta-analysis of the inbuilt trial says that there are certain subgroups of PPF where nintedanib has a greater magnitude of preservation of FVC. The classical examples will be CTD-ILD. Of course, in CTD-ILD, as all panelists have mentioned, there is a separate study with the name of Sen6, so that's not an issue. Even in occupational ILD, idiopathic and SIP, the decline in FVC, or rather the preservation of decline in FVC was very impressive, whereas it was not that great in fibrotic HP, fibrotic sarcoidosis, and undifferentiated ILDs. So I don't think we will have a study of the magnitude of the impulses or inbuilt or Sen6 when it comes to each of the subgroups or subtypes of PPF. Having said that, as I previously mentioned, there are small studies which say that probably it might be helpful in those subtypes of PPF or sub-etiologies of PPF also. I would just throw light to one particular post-hoc analysis. There is the clean UIP study, if I am not mistaken, clean IPF study, where various antifibrotics were taken as a standard arm, and antibiotics was added as a treatment arm, which again was terminated prematurely because it was seen that antibiotics don't give any further addition to that. But in that particular study, they just looked at, they in fact compared the FAC preservation of pirfenidone versus nintedanib, although it was not the primary intention of that study. And what they found out was at 1 year, the preservation of FPC was much better with nintedanib as compared to pirfenidone in IPF. It's not PPF. But in the second year, by the end of second year, the preservation of lung function with both agents was almost similar. So the general statement here is that nintedanib has a efficacy pretty early, within months, whereas pirfenidone, the total effect usually we get after the first year of. So that needs to be taken when we play down on pirfenidone and play up on nintedanib. That is my personal take.
Yeah, thank you. I think there is definite consistent FVC benefit, survival impact also. So with the thing is, who benefits the most? We should find the right patient and then institute the right drug. Next, we'll move on to Dr. Parul. Which patient, we have been talking about the inbuilt trial, which patient populations in the inbuilt trial benefited most from nintedanib?
Yes, ma'am. I think this is very, very important trial. InBIT trial it was specially done to see the the effect, or I would say the FVC decline among different groups, where it has been found that the annual FVC decline with the UIP group, UIP fibrotic pattern subgroup, was actually quite less as compared to the placebo, with a significant p-value. And it was like there was a great difference between the UIP fibrotic pattern group, like for example 82.9 ml per year decline versus in placebo 211.1 ml decline per year. So this study was published in NEJM 2019, and we all know this study, and it is published by Flaherty et al. Only thing which I want to highlight here is that UIP like HRCT patterns subgroups are affected, are benefited the most by nintedanib. But again, as we discussed, autoimmune ILDs like rheumatoid, like scleroderma, like MCTD, mixed connective tissue disorders, were also having lot of improvement in this, as well as benefit was also observed across other ILDs like hypersensitivity pneumonitis, autoimmune ILDs, idiopathic NSIPs, and unclassifiable ILDs. But most important group which was benefited was UIP pattern, and followed by these collagen vascular related RA, scleroderma, and MCTD. So we would recommend this, that from this trial, that nintedanib should be used for these particular subgroups and may be effective in other groups like HSP, NSIP, and unclassifiable diseases. This is the conclusion of this study, and very important study. I think this is one of the landmark study for nintedanib.
Yeah, true, very true. I think the message is, what she has said is really clear, crisp, clear, and I think the message should grow across the audience that if it is fibrosing and if it is progressing, nintedanib definitely helps. So we'll move on to the next panelist, Dr. Barney. What's your baseline workup before starting nintedanib, and how often do you check your liver function parameters in the first 3 months?
So now we have diagnosed PPF. Now we know nintedanib is the way to go. So what do we need to do before that? So one of the rare side effects of nintedanib is thrombocytopenia. Nintedanib cannot be given with a create clearance less than 30. So, and it causes a common side effect apart from diarrhea is affecting the liver functions. So for these 3 reasons, the baseline tests are a full blood count, serum creatinine, and a liver function test. If these are okay, then we go ahead and start nintedanib at full dose of 150 milligram twice a day. And if there is, now the major thing to monitor for is actually the liver functions. And it has been shown that if it does cause liver function impairment, it is more common in the first 3 months of initiation. So it is most appropriate to do liver function tests every month for 3 months. Transaminitis is more common as compared to hyperbilirubinemia. So one way of kind of cost cutting is probably just to do transaminases, but we could do a bilirubin as well, if not every month, at least at the end of 3 months. Once 3 months has passed, then we need to repeat only every 3 months, because the likelihood of them having liver impairment after 3 months is going to be less likely.
Thank you. The most important thing in India is we have nintedanib and we have pirfenidone. So if you have side effects of nintedanib, you can still try pirfenidone, which is not available widely across the globe. So we need to be very clear when instituting this nintedanib, because there are other drugs which we are using together. We should be crystal clear on what side effect it produces and which group of patients you are introducing. So don't forget that nintedanib can also have, you cannot give nintedanib to patients who are already on anticoagulation, coronary artery disease. So we should remember all the side effects of nintedanib and properly monitor these patients, whether nintedanib is fine or they are suffering due to the side effects. So with that, we'll come back to pirfenidone. Dr. Jai, so with which we have, coming back to pirfenidone, which we have used for a longer time in India, as I said, compared to, it was there previously, it was the first drug introduced. Do we have any meta-analysis, and what are the results pointing to its efficacy in PPF?
There is a meta-analysis was published in about 2022 in the Annals of American Thoracic Medicine, and it took two studies and basically showed that there was a decrease in FVC. The rate of decrease reduced by about 100 ml between pirfenidone and the placebo, as well as the 6-minute walk distance also improved by about 25 meters compared to placebo in the pirfenidone group. But the numbers were small, and so the certainty of evidence was quite low. But it is a potential drug, especially in patients where you are not able to use nintedanib. Definitely pirfenidone can be tried in those patients.
Yeah, see, that's the message. So of course, nintedanib is your first choice in PPF. That is proven data is there, but the signal for pirfenidone is really faint. We need some more studies. But in a special case where your patient is not tolerating nintedanib, I think you can go ahead with pirfenidone in our country. So the next thing is we move on to Dr. Rahul. If patient is having drug-sensitive tuberculosis and patient is on rifampicin, then which antifibrotic will you use and why?
I think this is a very important question, because we do see patients having tuberculosis and underlying ILD. And the main reason why we are talking about this question is because these antifibrotics are metabolized by hepatic enzyme and causes drug-drug interaction. There are two components to this. One is the efficacy of these antifibrotic goes down with rifampicin, and second, that both are hepatotoxic. So ideally, you should stop antifibrotic in these patients if your patient has active infection, because it is not going to help in that dosage because of the suboptimal dose. Even the guidelines suggest when the patient has tuberculosis, active tuberculosis, you need to treat tuberculosis first and then restart antifibrotics. But when we are talking about this progressive fibrostic disease, it is very difficult and justify that the patient should be off antifibrotics and should be treated for antifibrotic. But there is no clear-cut answer anywhere for this. You need to look into the progression, whether it is that fast that the mortality with progressive fibrosing ILD is going to surpass your infection profile,
Super. That's clear message. So if you have rifampicin and if you have active TB, treat the active TB first. So sometimes you can go for pirfenidone or wait and watch policy. So we'll move on to the next panelist, Dr. Rajesh. So it's observed that starting antifibrotics has become a knee-jerk movement reaction to all of them. Like even the general physician starts antifibrotics. Even before coming to us, patients are all on antifibrotics. So when are antifibrotics not indicated?
Ma'am, the knee-jerk reaction is totally unacceptable, ma'am. That's one thing that I can be very clear, and I think all the panelists will agree with that, and you also will agree with me. Now, if it is a clear-cut IPF based on the multidisciplinary discussion and all, yes, you are justified in starting upfront. Other ILDs, non-IPF ILDs, as of now, if you can demonstrate a progressive pulmonary fibrosis phenotype despite your best of treatment, then yes, you are justified. And maybe some of those CTD-related ILDs like scleroderma or RA with the UIP pattern, you may be justified in starting upfront. Otherwise, you demonstrate progressive pulmonary fibrosis despite the best of treatment, then you start off with antifibrotics. We have seen this knee-jerk reaction in COVID. Many of those post-COVIDs, it may be just atelectasis and all, reticulations and all. They are not real fibrosis. They may be vasculopathies. They just disappear in a matter of few weeks in HRCT. There's absolutely no need for fibrosis in such cases. There should be a progressive fibrosis, self-sustaining fibrosis, which is likely to worsen in the absence of antifibrotic therapy. Then only you are justified in starting.
Thank you. Yeah, that's also a clear message. So if there is no progression and if you feel your inflammation is reversible, like if you have untreated connective tissue, untreated HP, and if you have other mimics, which we discussed earlier, it's due to, viral ARDS, or you have pulmonary edema, you have pH, which is overlapping. Clearly, there is a big no to all these groups. So don't antifibrot the fixable issues. A treatable, don't miss the treatable trait in this whole thing and then go for the antifibrotic treatment. So I think we have come to the end of our discussion. I think no talk ends without the latest and the, game changers. So there is one trial which Dr. Rajesh talked about, the Fibroneer ILD trial, which was showing a game changer and promising results with nerandomilast. So let's ask Dr. Barney, what is his take on this, whether it is an add-on to antifibrotics, or is it a standalone option, or even is it a first-line contender in selected ILD subgroups?
Yeah, thank you, ma'am. I think after a long time, the Fibroneer trial brought up a new drug called nerandomilast for both for IPF and for PPF. I think some of the details Dr. Rajesh did give. So the Fibroneer ILD, which was for PPF, used placebo in one arm, the nerandomilast 9 mg in one arm and 18 mg in the other arm. And it's important to note that the background treatment was not stopped. So there were patients who were on antifibrotics, and they particularly nintedanib, and they tolerated. So they were on PPF, nintedanib, and they were added on with nerandomilast. And there was further, there was decline that was decreased, or there was the rapidity of decline was decreased in the group which had nerandomilast added to nintedanib as compared to the group which didn't have. Of course, some patients were not on nintedanib. They were only on nerandomilast, and they also fared better compared to placebo. The other important thing that this study did come, although it was not the primary objective, is there was a mild but important, significant improvement in the mortality also. So this is the first time a trial is showing some mortality benefit in PPF, which was actually not there in the Fibroneer IPF group. Now, this is not the primary objective of the trial. So we need to take it with a pinch of salt. But there seems to be a promising drug. Now, where exactly to place it? Probably it will come months down the line or a year later to India, where its position will be very crucial. So I think by the trial design, it has to be given only like a first line and then as second line. Can we give nerandomilast upfront? We don't have enough evidence to do that as of now. Probably further trials are required to either head-on compare or because it won't be ethical to compare it against placebo. So that is where we stand, but it is showing promise and further trials will clarify things. But when it comes again, I think we need to really monitor the use in India. Otherwise, like how nintedanib is being given, everyone will receive combination and everything, because the combination tolerability was much better than series where nintedanib and pirfenidone were used, where the tolerability was abysmal. Whereas here, although like Dr. Rajesh mentioned, 50% had diarrhea, but still they were able to tolerate and complete the trial in a majority.
Yeah, I think so. We need to wait for some more time. I think the results were published in June 2025 in NEJM. So I think still the drug is also not available. So we need to wait. So I think it looks like a game changer from all the studies. It looks very promising. So I think nerandomilast is not yet the superhero or the solo hero, but it might soon be a new addition to our armamentarium of antifibrotic squad. So with that, I think we will take some questions from the chats. Okay, so there is a question on what are the limitations of HRCT in distinguishing progression due to fibrosis versus coexistent inflammatory activity. Anybody wants to take this question? Limitations of HRCT in distinguishing progression due to fibrosis. So this is the $1,000,000 question, you know.
Yes.
In any ILDs, I think the point is to differentiate what component is due to inflammation and what component is due to fibrosis. Very, very, very important distinction. I think postgraduates should be taught ILD only in this way, because that only means there is some treatment and you can do something to the patient. So really say, so as Dr. Rahul, I think he explained that very well. You know, like if you see a ground glass opacity and if you see a traction bronchiectasis within the ground glass opacity, then it is definitely due to fibrosis. If you see an isolated GGO with surrounding lung which is not showing any fibrosis, then that is due to maybe your viral ARDS, maybe your pulmonary edema, maybe anything. So subtle signs like this, postgraduates and consultants need to know which component is inflammatory and which component is fibrotic. Ultimately, when you start treating the patient after a month, you should see how the component disappears. That also retrospectively, you can think whether it is inflammatory or fibrosis. Any other panelists want to add some more points? You can.
Ma'am, you very correctly said, ma'am. I think ground glass opacities probably needs follow-up. If ground glass opacity is associated with honeycombing and traction bronchiectasis are definite signs of fibrosis. So ground glass opacity is the absence of traction bronchiectasis. Probably you need to follow up. They may progress subsequently into fibrosis. They may disappear because they may be an alternate pathology. They may disappear because they are inflammatory and the anti-inflammatory treatment has taken care of it.
I think when we are talking about, ground glass opacities in non-IPF ILDs, so what we are trying to see whether there is a cellular component or it is all fibrosis. So these are the things that we need to identify. I think the prototype that we can take here is hypersensitivity pneumonitis, which has both the components. It has acute component also, and it has in the chronic part, it has fibrotic component also. So why we want to identify these two things is because if the patient has cellularity, probably immunomodulator are the best therapy to your patient. And if it is all fibrotic, immunotherapy or immunomodulators is only going to give more immunosuppression and risk of infection in these patients. So I think when there is a significant confusion patient is not fitting into a proper IPF diagnosis, patient is having high inflammatory marker in terms of ESR or CRP, biopsy or BAL lymphocytosis gives you a good idea whether these patients are the candidate for immunomodulator or antifibrotic.
Thank you. That's wonderful. So the point, the message is be very clear. Also use biomarkers to help you. That's the message Dr. Rahul has said. And also, why are we so much worried? Take that message. That's very, very important because this is the only reversible part of the treatable trait of this ILDs. So if you miss this bus, then it is very difficult. I think here this will be a game changer. If you give steroids to these patients, they will benefit a lot if inflammation is the problem in these patients. So the next question is Dr. Jay to Dr. Jaya. Discuss the challenges in differentiating progression due to true fibrotic remodeling versus treatment-related lung toxicity. Anybody wants to take this?
I think treatment-related toxicities generally we see in patients who are on rheumatology, and there is always a debate whether the methotrexate is going to do fibrosis in your patient who are initially normal, or the other subgroup of patient where patient is being given chemotherapies or radiotherapy where we have these fibrotic component. But I don't think the antifibrotic has very much role when we are talking about radiation-induced or chemo-induced fibrosis, and these are the subgroup of patients in which steroids do a good better job rather than antifibrotics. But yes, patients who are progressing CTD-ILDs, I think antifibrotic has a role, and you need to just rule out the infection first before labeling these patients as drug-induced toxicity.
Yeah, correct. Very true. So this drug-induced toxicity is very, very difficult. Most of the rheumatologists who are patients on RA will be having methotrexate. And then when the patient becomes sick, for us, it's very, very difficult to differentiate whether it is methotrexate-induced progression or is it exacerbation of ILD or it is something else. So these type of scenarios we face day in and day out. But be aware of the drug toxicity because that is also another treatable part. You remove the drug, the patient is going to do well. So I have recently read 2 or 3 articles on rituximab producing, ILDs. So it's like there are few papers and clinical scenarios. Can you believe this? So the go-to drug in your immunosuppression will be the final rituximab, and then that produces ILD and progression. That's very this thing. So we should be aware of all this, and differentiating this from progression is really a tough job, and no single test can prove. You can only stop the drug and see the progression, and that's how retrospectively you can say this is due to drug-induced or not. So the next question, in which scenarios should immunosuppressive therapy be continued versus switched to antifibrotics in progressive fibrotic ILD? In which scenarios should immunosuppressive therapy be continued versus switched to antifibrotics in progressive fibrotic ILDs? Anybody wants to take this?
I think baseline anti-inflammatory will be continued in most cases. I don't think anybody is going to be brave enough to just stop the immunosuppression and just go for antifibrotics unless you're sure that you're dealing with only pure IPF. With any other PPFE, as your baseline treatment would continue. Otherwise, you are risking progression because you're not treating the underlying disease enough.
Yeah.
Baseline, can I comment, ma'am? Can I comment?
Yes,
yeah. See, baseline, basically, as we already discussed, the etiological factor of the disease has to be treated. And that has to be continued even if we start with the antifibrotic. So antifibrotic may not decrease the inflammation. So we have to give immunotherapy or immune suppressants specifically in the CTD-ILDs, and then we can add on the antifibrotic. So there is nothing like stopping this and going to this. But yes, basic treatment should be continued. Even I believe that the basic minimal treatment should be continued with the antifibrotics.
Exactly, that's true. So always please remember, in these group of patients, it's not always the pulmonary part which we are talking about. There will be a non-pulmonary part there. The patient will be having joint pain, will be having other issues which might need this immunosuppressive therapy, even if it is not the lung. Please, this is case by case basis on a patient. So you may not need the immunosuppressive therapy, but these patients, for example, RA patients, for the non-pulmonary part, they might need immunosuppression. So you see the patient on the whole and then take a call on that. So the next question.
One thing to add, in idiopathic fibrotic NSIP, suppose we label, and now you have progression and now the CT is looking like UIP. Whether you are revising your original diagnosis where it's actually IPF, you have mislabeled it or did not realize it's IPF, is probably the only situation where we would have stopped the anti-inflammatory and switched to antifibrotic. I think Dr. J was also referring to something like that.
Excellent. Yeah, that's another point. Very well made. Yeah. So the next question is about how do clinical trial data in Bill census relief support the use of nintedanib pirfenidone in non-IPF PPF? I think we have discussed so much regarding that. We'll skip that question. What are the mechanistic differences between nintedanib and pirfenidone, and how might these influence patient selection? Good, super. So I think all of us discussed about this. So in a patient, if your patient has a PPF and then he is having some outdoor jobs, don't use pirfenidone. If your patient has a lot of gastrointestinal side effects, then both of them have gastrointestinal side effects. You need to choose the worst from the best, something like that. So the next thing is if your patient is on anticoagulation, coronary artery disease, then you don't give nintedanib to that patient, give pirfenidone. So choose the right patient for the right drug. Do the panelists have any other suggestions?
There is some data on delayed wound healing with nintedanib particularly. So if the patient is immediately, like we've had patients who are going to go for a cabbage, then we prefer pirfenidone over nintedanib.
Yes, exactly. That is also another very valid point. So if your patient is anticipating some surgery or something like that, then don't give nintedanib. And then also pirfenidone, we should remember photosensitivity. That's the important point here. How would you approach management of a patient with PPF and significant pulmonary hypertension where antifibrotic and vasodilator therapy may conflict? Fibrotic and vasodilator therapy. Anybody wants to take this? Patient with PPF and significant pulmonary hypertension where antifibrotic and vasodilator therapy may conflict.
I'm not sure what that word conflict means here by the person who's asked the question, but I think the question to ask is the primary, I don't know if they're trying to ask, is the primary disease that led on to PPF, if it is like a CTD, ILD, and the pulmonary hypertension is part of the CTD, only then they require pulmonary vasodilators. If there is not a cause, for example, there is HP, it progresses on to PPF, and there is pulmonary hypertension because of that, there is no indication for pulmonary vasodilators. The only thing that is probably coming up beneficial is like inhaled treprostinil in ILD associated pulmonary hypertension. But otherwise, I am not aware of any drug interaction wise contraindication. I don't know. Others can contribute.
So I think in patients who are having pulmonary artery hypertension along with ILD, the first thing that you need to see whether it is a part of ILD related pulmonary artery hypertension or it is out of proportion hypertension. So once you decide that patient has mild pulmonary artery hypertension due to hypoxia and ILD, I think you need to just treat the basic disease of ILD, give them good support through oxygen, pulmonary rehabilitation and other part. But when you believe that this pulmonary artery hypertension is out of proportion, then there is a need of giving anti-PH therapy in these patients with limited benefit. So there is no clear-cut guidelines that how to give, what to give. But yes, there are some trials, I'm forgetting the name. Ambricertin is the drug that you can choose in patients who has ILD and associated out of proportion pulmonary artery hypertension. But for mild to moderate hypertension with significant ILDs and respiratory failure, probably this hypoxia is causing PH in these patients. Optimizing these patients with therapy other than your drugs like oxygen and pulmonary rehabilitation do a lot of good job to your patient and improves the quality of life.
I'm not sure what the question was, but I think I think there is no contraindication for. So if you have pulmonary hypertension, the first important message is You need to risk stratify the patient, whether it is pre-capillary, post-capillary, whether it is PAH or PH. It's not, because that contributes to your treatment and the entire thing. And the pulmonary hypertension, I think if you take, for example, scleroderma, it can produce group 1, group 2, group 3, group 4. So it's not that simple question to answer. But I think the message is clear. If you have PH, risk stratify, place them in the appropriate group and give the appropriate drug. Differentiate between PAH and PH. Just don't give pulmonary vasodilators across the board for everybody. So the next question, how does the rate of FVC decline differ across various ILDs? IPF versus RA-ILD versus chronic HP that manifest as PPF. So the rate of FVC decline differ. For that matter, I think you should know that all the various trials, the INBIL, the census, the Cotrin, the UILD, all the trials, each one used one criteria. Some used absolute decline, some used relative decline, some like the criteria was so all over the place in all the trials. But I think the PPF guidelines in 2022, the ATS ERS, they have agreed on all this trial and they have made a consensus on this is what you should be doing. This is the domain you should look for. That we have discussed repeatedly. So the rate of FVC decline differs across various ILDs. That depends on the patient and case by case basis, I think. Anybody wants to add some more points or suggestions?
My take on that would be, madam, in general, IPF has a slightly higher rate of progression than non-IPF ILDs. However, as you very correctly said, it's totally individualistic. And most of those large-scale data express that rate of decline as a range. So there may be a patient with IPF who has a 4% decline over 1 year, whereas someone with RA who traditionally has a slow fall, an isolated patient can have 8 to 9% decline over 1 year. So it's entirely individualistic. But as a general rule, probably what we can say is IPF has a higher rate of FVC decline than the non-IPF ILDs. Especially so if the non-IPF ILDs are taken care of by proper treatment. And second thing, I think I showed in one of my slides that the rate of decline may alter with time. Like someone who has a high rate of decline in the first year might have slightly lesser decline in the subsequent years and even vice versa. So the probable message that we can pass on to the delegates is that follow up your own patient, time will tell the answer.
True, very true. Superb. Yeah, okay. So what are the challenges in designing clinical trials for PPF given the heterogeneity of underlying ILDs? He himself has given the answer. It's a heterogeneous disease. I think it's very, very difficult. You have everywhere, it is scattered, all types of different ILDs. And some are very, very responsive to immunosuppressive therapy. Some are not responsive. So it's really a tough job. Are there any people who are doing, panelists who are doing studies on all this? In designing clinical trials for PPF, given the heterogeneity of underlying ILDs. Anybody wants to add any points to this?
I don't think, ma'am, we are designing, but maybe some of us might be executing some of the designed trials. That's probably the best that even our panelists are doing. I feel probably what he's meaning is because PPF is a heterogeneous mix of various etiologies, probably we need to have disease-specific PPF trials. Then that may be challenging because to get those required numbers of each specific etiology progressing into PPF may not be that easy.
And also, I think it is place specific, North India may have a different, each place, wherever there is a HP which is prevalent, you will have a different scenario, and South India may be different, North India may be different. It will need a not only disease is not only heterogeneous, it also, depending on the regions, it's heterogeneous. It's very, very, it's very, very difficult, I understand. So
it will also depend on the patient treatment, like whether a patient is optimally treated for that cause or not. For example, in autoimmune diseases, we have to treat that proportion also. So there are it's a multifactorial basically study. So it will also, the age will also affect this, as well as the ethnics, as well as the area, as well as the subpopulation. So it's not easy to design. As sir told that we should take up a single disease-wise trial so that it can give us better result and better understanding of the same population.
Yeah, so the message should be loud and clear that forget the IPF, all the other PPF, treat the primary, treat the underlying cause, optimize the primary treatment, and then decide on all these things. You know, like it's so difficult, it's so heterogeneous that it's so difficult to do a study. What role does psychological support play in management of IPF? I think we'll skip that question. That's not so important. Definitely, it plays a role in any disease, not only IPF, that too being a chronic disease. I think definitely you need a psychological support. These are all the non-pharmacological part of our PPF. We have not gone into those details today. That's a separate topic to discuss on a day, I think. Any panelists want to add more? Okay, the next
just one thought. There are a lot of questions and some are on IPF. Probably we should leave the IPF and take the PPF ones.
PPF, okay. Are there any digital tools that can, oh, that is on IPF, okay. What is the role of pulmonary rehabilitation in improving exercise capacity and quality of life in PPF? That's what I told you. That's the most important non-pharmacological part of our PPF. Anybody wants to add any points? That's a discussion by itself.
I think this is one of the gold standard that for every patients of PPF or ILD or IPF, you need to enroll these patients into pulmonary rehabilitation for overall improvement in the quality of life along with the drug and medications.
The next question is, do you think there is a challenge in accessibility to antifibrotics in India?
Not at all.
It's everywhere.
Not at all.
At least for us sitting in this major towns, I don't think there is any challenge. But anyway, Lupin people are also there who are anchoring this program. I think they should be taking care of accessibility.
Whoever asked that question, I think they can get back to them. Which underlying ILDs are most likely to evolve into PPF? Anybody wants to take this? So there is no, defined criteria as in the initial talk, Dr. Rajesh has said, no. Every 1 in 4 patient of your ILDs are going to progress with PPF. So approximately. So you need to find the correct patient who progresses and then decide, define him as PPF or whatever. So it's not like this ILD progresses, this doesn't progress, it's not like that. When should antifibrotic therapy be initiated in PPF? At diagnosis or after documented progression? I think we discussed about this, right? So anybody wants to add any points to that? So be very clear that at the time of diagnosis, all of us, I think we face these patients every day. At the time of diagnosis, already they'll be progressing and they would have come to us very late only. But that is different from what the guidelines are talking about. Progressive pulmonary fibrosis is you need to demonstrate over a year with the definition of all the domains which we talked about in a non-IPF patient over a time and ruling out other causes. So if it fits into that criteria, label them as PPF. So at the time of diagnosis, you feel there is progression. I told you there is an entity called rapidly progressing ILD, anti-MDA5. Rule out all those things if the patient is progressing very fast. What is the current evidence for antifibrotics? I think we talked about. Can artificial intelligence or quantitative image improve monitoring of progression? Yes. Anybody wants to take that question? Casper. No, there is a...
There are a lot of tools like Caliper is one of the tools. So these quantify the amount of fibrosis. So it has been used for diagnosis and quantifying amount of fibrosis, inflammation. And there are now studies which are coming up, which are looking at in compared to baseline, how much progression has increased and so on. So
can use
there is an evolving role.
Imaging also. There are so many tools, but all those are for research purposes. I think any of you using it?
For clinical purposes.
Not available in the market, ma'am. But yes, future radiology can use it. I think can be
No,
helpful
I
in
think
detecting early fibrosis and so.
I
Yes.
think the tool by the name of lung texture analysis is available in the market, and few centers are doing it. But doing the follow up with this, because I personally believe that it quantify or sub quantify fibrosis in your ILD patients. But this is a tool to define the numbers per se right now. I don't think it has any clinical utility so far in any of the trials.
I think
Yeah.
Dr. Jankaria uses calipers for all his
Yes.
patients now.
No, the thing about calipers is it's like, even you see a CT scan with your naked eye, you're not able to identify the progression, the calipers diagnosis. That's how they are projecting it. So maybe in the future we'll have to watch this.
It requires longitudinal evaluation to say that it improves overall outcomes, mortality, and all that.
And I'm made to understand by this people who use it, ma'am, that if your scanning technique is not proper, then it causes a huge mistake in determining the percentage of fibrosis and all those things. Like if the breath hold is not that great, then maybe atelectasis can be misinterpreted by this machine as fibrosis and all those things. So I think technique is extremely crucial, even more crucial than our routine HRCTs when we use this AIs.
Exactly, superb. That's a very, very important take-home message. If your CT is not done properly with the protocol mentioned by Fleishner Society, inspiratory, expiratory, prone, all those things, I think ILD becomes very tough, and not to say about progression. We are going to really miss it. Do serum biomarkers KL6, SPD, MMP7 have a role in routine clinical practice? Anybody wants?
No.
Not in routine clinical practice.
In
It's
all-
a search-based tool. I think KL6 is now available in some centers across India. I'm not sure. Do anybody
Yeah,
want?
it's available. There are initial studies showing some promise but it's not as a single value. It's behaving more like AS in sarcoidosis. So we really don't know where it stands, but in follow-up, there is a evolving role.
And I think this was marketed for identifying the exacerbation in ILD rather than the progression of these diseases. So I don't think any tool so far is defining progressive ILDs. So KL6 was for identification of predicting early exacerbation rather.
Any idea about the cost? I think it should be really costly also, right?
I think it was costing somewhere around 12,000 rupees. We tried in
No,
few patients.
No,
Then we stopped.
1,000.
No,
Right.
I think it's
1,000 rupees.
slashed. We have 2,000 rupees and all we get now.
Okay. We have stopped using it nowadays because I don't find any utility of this test. We used it initially, I think 3 years back or something.
Okay.
But currently there are some studies which have come up where progression KL6 is going up, although it's not yet come to a diagnostic level. But I agree, earlier it was with predicting exacerbation, but now whether progression also, because it's produced by the type 2 pneumocytes, it's a glycoprotein. So more the fibrosis, more KL6 will be produced, and it will enter the circulation and get detected. So, but it's too early to go into it for routine clinical care.
Okay. So the next question is about how often should PFTs be repeated? I think we have done with that question. We have already answered that. What is the role of HRCT in early detection and monitoring of progression? That also I think we have discussed. Which underlying ILDs are most likely to? That also we have discussed. How do you approach oxygen therapy in these patients? So the non-pharmacological part of the PPF we have not discussed in our panel. That's not the topic for discussion now, which is also the game changer and most important: oxygen in a relevant patient, NIV in a relevant patient, pulmonary rehabilitation in all patients. So I think that's a topic for discussion on a separate day. Anybody wants to add anything to that? Okay, the next question is, should antifibrotics be continued in advanced disease or near
Absolutely.
transplant referral?
Yes.
Yeah, that's all.
Yes. In fact, the fear of before surgery stopping is not for transplant. We should continue till transplant because transplant is an urgent thing and you can't stop. And there is some evidence towards, like if you're giving nintedanib, there could be post-transplant some benefit in terms of GVHT. There are some signals that are coming up.
Okay. So what new therapies or trials are most promising for PPF? I think we just talked about that, right? Nirandam last. Do you foresee precision medicine biomarker driven treatment? That also we have just, there is no game changer in biomarker and it's not commonly used. It's only for research purposes. Could biologics targeting TGF-A or integrins be the next big step? So TGF-beta is almost similar to what we discussed, no, in the Fibroneer trial. So we have to watch that space. At present, no. Is there a role for cell therapy, stem cell therapy in PPF? That is also, anybody wants to take that question?
I don't know.
It's
There's
not
some,
yet documented.
there's
Other
some,
but, sorry, yeah.
sorry,
Please,
I think,
continue.
yeah, I think on in systemic sclerosis, there was some trials on stem cell therapy on generalized. I don't know if about specifically for ILD, but there was some trials on stem cell therapy in systemic sclerosis, but not in general ILD.
Yeah,
Yeah.
not just some trials. Those have now come part of guidelines now.
Yeah.
So it is part of standard of care in SSc-ILD in certain subset if
Yeah.
they fulfill certain criteria. But in all others, it's yet to evolve.
But is anybody doing it? I'm not aware.
Yeah, we in CMC Vellore, we have options to do it. We just have a group between hematology, pulmonary medicine, and rheumatology, where we are identifying patients and trying to shortlist them towards stem cell in a specific subgroup of SSc-ILD.
Okay. So it is only in SSc-ILD.
Yes.
Upcoming trials, I feel, I think LPA1 antagonist could be the next thing after Darando's last. I think we have something that is definitely coming up in IPF, that is admin parent. Maybe it might come in PPF also. The other one is TGF-beta. I think we have a negative trial in IPF. I think, if I'm not mistaken, pembrolizumab, that is a human monoclonal antibody against TGF. I think there was a negative trial in IPF, so I don't think anything has come up in PPF as of now. But maybe, better trials might dictate better outcomes maybe.
But as of now, I think if your patient is getting sicker, better not go for all this, go refer the patient for a transplant.
Yeah, perfect, man.
Yeah. Genetic screening identify patients at risk before fibrosis develops. Yes, in familial ILDs, you can screen the family. And I think you can. Anybody wants to take that? Could genetic screening identify patients at risk before fibrosis develops? So it should be an index case, and then the family members, when they are screened only, we will come to this, right? Other scenarios, genetic screening. Of course, we do genetic screening for patients who are progressing out of proportion to this MUC5B gene. So many things we can identify, who will progress, whom you should refer for transplant early. Genetic screening definitely is indicated in patients, in specific group of patients. Any panelists want to add some more to that?
Maybe, ma'am, telomere is something that's coming up.
Telomere marketing, MUC5B, yes. When should a patient with PPF be referred for lung transplant? That is another topic separately by itself. That's a discussion. Anybody wants to take that?
More than 10% decline in FVC over 6 months while on maximal treatment, which will involve the anti-inflammatory and antifibrotics.
So we should
In
remember.
other words, we are progressing on antifibrotics, then they need to be referred.
Yes. So we should remember that lung transplant in India, waiting for the lung takes a year. So don't allow your patient to deteriorate till the last, and then, death comes before the transplant. So that should not be the scenario. It should be really when you diagnose PPF and then you have optimized your treatment and still your patient is progressing, please think of lung transplant early. At least keep it in mind or discuss with the patients and the relatives. How effective are immunosuppressants in PPF compared to non-progressive ILD? So this is again in a case-by-case basis. If you have HP, if you have sarcoidosis who responds to steroids, I think that will be a game changer. In fact, in these group of patients, you should select the ideal patients who will respond to immunosuppression. Is the issue.
I think in all non-IPF patients, we are starting our patient with immunosuppressant. And when they are progressing, then we are considering antifibrotic other than systemic sclerosis. So most of these patients who are progressing are not responding very well to immunotherapies,
I think we
or
have,
rather immunosuppressants. Yes.
yeah, I think it's almost 10:30 and we have come to the end of our discussion. So thank you all the panelists. Today we had seen PPF evolve from, a fussy term into a real world practice compass. The message is simple. Catch it early, confirm it smartly, and treat proactively. Because in PPF, every small drop in FVC, it's like it should be treated like a gold dust. So you should take steps to diagnose these patients early. So thank you very much for all the panelists. I have learned a lot today. So at the outset, I would like to thank Dr. Amita Neni. She has the energy, vibe, and the potential to arrange such great webinars and to always be with us and help us through this. Thank you, team ICS. I think we will thank Dr. Rajadhar, Dr. Samaria, Dr. Amita Neni, and Dr. Lupin for giving us this platform where we can discuss so many things and learn from each other. Thank you very much for this webinar, and a good night to all the panelists. Thank you.
Thank you. Good night,
Thank you,
everyone.
madam.
Thank
Good
you.
night.
Thank
Good
you,
night.
everybody.
Thank you.
Bye.
Thank you so much. So from here, I'm ending this meeting.